You know, on Wednesday, AstraZeneca acknowledged a key mistake in their vaccine dosage received by some study participants, right? Now, this added to questions about whether the vaccines, this apparent spectacular efficacy will hold up under additional testing. What were your main takeaways from the AstraZeneca acknowledgement of its error? What questions does this raise about the vaccine and trials in general?
So it has two ways of looking at it. The first way is that what AstraZeneca said, that this was a blessing in disguise, because they found that in around 2,700 individuals who were vaccinated with half the dose first and the full dose later on, they had a higher efficacy than the group that got both full doses in the first part and the second part. They're still trying to explain this scientifically. It seems that it's related. They're trying to say that it's more related to the immune system getting tuned in and then having a booster effect.
Okay.
But I think the bigger question is that how could a trial be done where they made this major mistake in such a large number of individuals of giving half a dose in the beginning and then the full dose later on. So that raises question on the quality of the trial in various parts of the country where it's being done. This is a multi-site trial which is being done in many countries. But to have a large number of individuals get half the dose in the beginning raises a lot of question in terms of monitoring and the other issues, that how closely were the safety part of the vaccine also monitored. So I think those are very, very important issues, because it puts a question mark on the quality of the trial.
Wow. So no, is that because we're in a rush? We're obviously racing against time. This has already been 1 year. Talks about vaccine coming in 2021, maybe even 2022. And so is that the concern here? Shortcuts?
So I think, so even if you this is something that we've said repeatedly, that when you're looking at a vaccine, the very important part of a vaccine is that it should be safe. You cannot have shortcuts on safety and efficacy. You may do things in parallel, and that is where one was able to decrease the time that usually takes for vaccine development, that you were able to do phase 1, phase 2, and then phase 3 in parallel, and you could start manufacturing also at the same time, rather than doing it in sequence, that you did phase 1, you analyzed the data, then you went on to phase 2, analyzed the data, then you went to phase 3, then you got regulatory approvals, and then you started sort of manufacturing the vaccine. Here, everything is being done in parallel to cut short the time. But that does not mean that you should have any shortcuts in terms of monitoring for safety and for efficacy is concerned. If that is done, then that raises a lot of questions. And when we're now talking of giving vaccine to healthy individuals and to a large number of people, we must be very confident that all the protocols were in place in terms of safety and efficacy.
So you're raising some crucial red flags. So is there then a cause of concern for the Indian trials also? Does this raise questions for India's Covishield, which is based on the AZD 1222?
I don't think so. In India, the trial was conducted and both the full doses were given in the beginning and in the second part. So what we need to do is look at the Indian data also, and I think the regulators will look at it more closely now, both in terms of safety and efficacy. And I'm sure the regulators in UK, where they will also apply for emergency use authorization, will look at it. And it's possible that in the other parts of the world, the trial may get extended a little bit to really get a hang of this part of the data that they have sort of discovered.
Dr. Guleria, you said, you mentioned in the in your first answer that efficacy is acceptable. So, you know, this leads me to ask, and I think this is a question a layperson may be wondering about. You read so much about vaccine efficacy, 95% efficacy, but you can give it to less than 50% of people, or 60% efficacy, but you can give it to 90% of people who should be getting it, so it can have the same or better effect. So the man on the street will be wondering, does a vaccine not have to have 100% efficacy to work? And does it only work? Many questions. Does it only work if everyone has it? Is it like polio? How does one make this trade-off? Higher efficacy but poor people, lower efficacy but more people protected?
So it's dependent. The first thing to remember is many vaccines don't have an efficacy of 100%.
Okay.
Even the flu shot that we give every year, the maximum efficacy is only 70 to 80%. So the issue here is, what are we trying to achieve by giving the vaccine? Our aim is basically two. One is to decrease the mortality. So if we are able to say that it gives good efficacy and effectiveness in the high risk group, that is those who have a higher chance of dying because of COVID-19, then we can say that this will actually be protective, and you may get exposure, but you will get a mild disease, you will not get a severe disease, and giving it to the high risk group will actually decrease the mortality. You may not have to give it to a large number of population if you're trying to decrease mortality. But here our aim is also to decrease the pandemic, to decrease the number of cases that we're getting, even if they're mild cases. And therefore, you will have to, even if you have a vaccine where the efficacy is low, but you give it to a large number of people, then you can break the chain of spread of the infection among the population, and thereby decrease the number of people who will get the infection, and thereby get the cases down. It not be zero, you will still continue to have small outbreaks of COVID-19 cases, but life will come back more or less to normal if you are able to do that.
So that is why then, Kate O'Brien, the director of the immunization, vaccines and biologicals at the WHO, had said on Friday that, the troublesome storage conditions of some candidate coronavirus vaccines and the associated high costs should not discourage countries from adopting them as an immunization means, and that countries may that the approach countries may take is to choose to use vaccines that require an ultra cold chain only for certain portions of the population. So that would be the former the example you're giving in the beginning, if you want to keep the death rate down.
Exactly, and let's also accept the fact that even if we have one vaccine, it's not going to be able to supply the entire vaccine demand for the entire world. So you will have to have multiple vaccines which may be available. And like we've said before, we need more data to say which vaccine is more effective in which group of ethnic variant group, or which high risk group, in the elderly, in younger age group, in people with comorbidities. And even if we have vaccines which are equally effective, if we have more than one vaccine, it will be easier to have a larger dose available to vaccinate more and more people, and thereby decrease the number of cases and the spread of the infection.